Good afternoon. My name is Ernesto Rodriguez, and I'm the Chief of Emergency Medical Services. Thank you for joining us today. We've got several folks that are going to talk with you today. We have Dr. Paul Hinchy, our Medical Director, who's going to talk with you today about some items regarding Ebola. We've got Commander Michael Benavides and Captain Darren Noack, Public Information Officers. They're also going to provide some information. Since the case in Dallas, Texas, has come to light. As you can imagine, Emergency Medical Services has received numerous questions, both from the public and from media, asking how prepared are we to handle a potential Ebola case should it arrive in our community. We think that's a fair question, and it's important that we provide answers so that you can understand how prepared we are. And it provides assurance for the families of our providers that their medics that come to work here every day are safe, and for the community so that they understand how safe they are and how prepared we are to manage potential cases. As you know, Austin Travis County EMS and our safety office and office of medical director has been monitoring the situation in Dallas, and we're all aware of what's going on, and we're tracking that and keeping a close eye on it. I'd like to reemphasize, though, that it's important to remember that an actual case coming here is relatively low risk at this point, and so we're still remaining prepared. And one of the most important things that we can do, oftentimes EMS is the first organization that gets involved in cases like this. So it's important for us to remain diligent and not take things for granted, and remain focused on what it is that we do. We're going to talk about three key points today. The first one is, how are we evaluating patients, so that you understand and our community can understand what to expect if an EMS comes to their house, an EMS unit with medics comes to their house, and may evaluate them and be asking questions as we assess them to see what's going on. The other thing that we're going to talk about are the steps that we're taking to protect our personnel and the community and our patients, even one at a time, to be sure that we're not giving them any kind of a disease, no matter what it is, whether it's Ebola or anything else. And then finally, what measures that we're taking to disinfect our equipment and our ambulances post-case. If we come into contact with any kind of infectious disease, how do we clean our equipment? How do we clean our vehicles so that you know that you're getting into an ambulance, it's safe and it's clean? So with that, I'd like to introduce Dr. Paul Hinchy to tell you a little bit about how we're going to be evaluating our patients.
Thanks, Chief. As the Chief said, I'm Dr. Paul Hinchy. I'm the Medical Director for the EMS system, so all our first responders and transport providers. As the Chief pointed out, one of the things that we know is that the initial responders, the initial healthcare providers in a system like ours and across the country, were often the first to come in contact with any infectious disease. And as healthcare providers, our greatest tool in addressing these things is knowledge amongst our providers, not just for things like Ebola, but for any infectious disease or any of the pathology we face. So when we first became aware of the outbreak in West Africa, we put out information to all our providers for just increased awareness of what the symptoms are, what to look for, and what questions to ask. When the CDC had an update in August, we sent out another notification to advise the crews of any changes. And then with the Sentinel case in the U.S., we notified the crews again last night as a reminder just what to look for in terms of symptoms, and then what questions to follow up with so we can provide early notification to our hospitals. And just as a reminder as well, patients are only infectious when they have symptoms. So our key element is looking for people with symptoms to identify and flag them. So just as a reminder, symptoms: fever, 101.5, symptoms flu-like illness, so things like headaches, muscle aches and pains, joint aches and pains, nausea, vomiting, diarrhea, abdominal pain, all included in our screening tool in terms of when we start to ask more questions. We'd follow up those questions with people fitting in that illness category with more questions about where they've traveled. We're moving into flu season. These symptoms are going to be very similar to any flu-like illness. So the key question is identifying those folks with flu-like symptoms and then following up with the travel questions. The travel questions are going to be the discriminatory piece. Otherwise, this is just regular flu-like symptoms. And with that, we use our standard precautions in terms of protecting our providers and protecting our patients. And with that, I'll turn it over to Captain Noack.
So once again, as Dr. Hinchy said, provider safety is obviously paramount for us. The key thing to remember there is that it's truly no different than any other day and any other infectious disease that we might come in contact with. As far as the Ebola virus, as was mentioned earlier too, EMS tends to be one of the first points of contact, so obviously early recognition and identification of those signs and symptoms and possibilities is key. But as far as the providers themselves, we utilize our gloves, and we utilize those on every calls, gowns that are fluid resistant and impermeable, eye protection, respiratory protection, including face mask. This PPE or personal protective equipment, it is and should be worn as you enter into the person's residence and throughout the whole entire time that we're in contact with that patient. At the point that we no longer are in contact with the patient, then that personal protective equipment should be carefully removed and then disposed of properly in a medical waste container at the hospitals. And with that, I will turn it over to Commander Benavidez, who will address the decontamination of our units and equipment.
Thank you, Captain Noack. As everybody has already pointed out, a lot of the measures that we currently employ and we currently institute in the department will be effective for not only treating and respiratory protection, but also when it comes into the decontamination and the of our equipment, whether it's porous equipment or whether it's not. Porous equipment, things that are probably routinely, disposed of, on an individual basis. For our non-porous equipment, some of the equipment, our monitors, we have, Santa wipes that are a disinfecting agent, and it is effective to kill Ebola, and that's something that we use regularly. So all of our equipment is disinfected with stuff that we currently possess. In addition to our equipment, we also can disinfect our units with what we call a Zymex machine, and this machine is connected to the ambulance and sends out an aerosolized product that disinfects the entire ambulance in about 15 to 20 minutes. So even if we did we came in contact with something, whether it be Ebola or anything else any other contagion, this Zymex machine, we could hook it up and, disinfect the interior of the ambulance in as little as 15 to 20 minutes, which is really great because it reduces the amount of downtime for an EMS resource to be out there. Also, that it is a portable machine. So if we were concerned about having to disinfect at a remote location, then it's portable and we could do that. Or we could also disinfect with that Zymex machine. We could any one of our EMS facilities, a station, an office. So anywhere that there might be concern. And again, it's not just for Ebola, but for any kind of contagion that we might run across in normal day-to-day business. And that's my side of things. I'll turn it back over to Chief Rodriguez, and thank you.
All right, so I think the key points here, one important point is that these precautions that we're talking about are universal precautions. We do them for everything. We don't want anyone to be frightened or offended if we walk into your home wearing gowns and gloves and masks. These are routine for us. And we don't want anybody to take offense that we're protecting ourselves. We're also protecting our patients by prevention of spread of disease, whether it's Ebola or anything else. So that's an important note to take. So the other thing that we're doing is the risk is low, and so diligence is important. It's important for us to pay attention to the details. It's important for us to ask the questions. It's important to ask questions about travel. Those things matter to us. So we'll be asking those questions, and we want our community to be prepared to hear that. We're not trying to treat anybody any differently. We're treating everybody the same way. but those questions are important to us, and we're being very careful, and we're asking everyone. So this is just something that we wanted to put out there and prepare everybody that's coming. So now we have some time to answer questions, if anybody has any questions.
Are you concerned that screening the patients for travel will take up time before you actually treat the patient?
We'll let Dr. Hinchy answer that.
So as part of assessing a patient with first contact in terms of how can we help you, immediately after that is the signs and symptoms that they want to tell us about. It really detracts very little from the care because it's just a simple process of questioning. It follows as a natural series of questions. The acuity of this ranges obviously pretty significantly from mild flu-like illness to catastrophic hemorrhage and unconsciousness. Towards that end of the spectrum, obviously interventions will be immediate because there'll be no history gathering component, but really no delay in patient care.
When did you start asking patients whether they traveled or where they traveled?
So our providers have been aware. I think our first update went out, I can't be exact on the date, but in April when we first started learning that this was going on. And we do this anytime there is a disease that may be a transmittable disease anywhere in the world. We send out updates so our folks are aware of symptoms that could be out there and questions that may be directed along that disease process line.
So since April, all of your first responders have been asking patients, have you traveled?
So we put out the first notification. We don't routinely ask them if they've traveled unless they have symptoms or that are worrisome for something that may be consistent with Middle Eastern respiratory syndrome, Ebola, or any of the other traveling world viruses or illnesses.
Though you guys are saying there's a low risk, we now know that this patient in Dallas went to the hospital, was treated, given antibiotics, and left. And there was some sort of breakdown in that screening protocol. How confident are you all in working together with the necessary agencies that there will be no breakdown here?
So I think the best way to avoid a breakdown are two things: education and redundancy. So part of what we do is we educate our providers. We do reminders. So for example, we'll talk with the command staff this evening to remind the crews to ask the series of questions. But also, because there are multiple contact points in the healthcare system, it may be annoying when you see your physician that they ask the same questions over and over again. We do the same thing. So a field provider will ask a series of questions. The hospital should ask the same series of questions, and through that redundancy, it decreases the likelihood that someone falls through the cracks.
But does the information get relayed from contact to contact to contact? Because that's where Dallas is saying the breakdown happened. The contact to contact, the information was not relayed from one team to another.
So I can't speak to what happened in Dallas. I just don't know enough about it. But in terms of our system, part of our awareness for our providers is to convey message if there's a suspicion. On further questioning in the hospital, that suspicion may be alleviated. But we have a low threshold for just advising them that there may be a possible issue.
Chief, you mentioned that everybody wears gloves, masks, and gowns. Is that on every call?
Not everybody's going to wear gloves on every call. We will wear a mask if we suspect that there is something airborne, disease that's transmitted through particles. If somebody sneezes, or sometimes we create spray when we're treating a patient. In those cases, we'll wear a mask and we'll protect our eyes as well. The most typical thing that you're going to see is medics wearing gloves. That's how we start. If the medics have any reason to suspect that this might be a case that they need to protect themselves with, they will wear a gown and they will wear a mask and eyeglasses as well. Any other questions?
I have some more.
Okay, great.
Nobody else does. So, besides the travel question and the I'm sure you always donned the gowns and that when you suspected an infectious disease, correct?
That's correct.
So what else, and issuing 3 alerts, what else have you done that are doing that's different?
Well, really, what we've been doing is running systematically through the system and making sure that we have all the pieces in place. So, as a matter of fact, even today, we were looking at what type of cleaning equipment that we have, making sure we have enough of it, making sure that all of our ambulances are equipped with the proper bags to dispose of any contaminant that we have, making sure that the specific cleaner that we're using will cover the broad spectrum of diseases that we want to protect ourselves from. Making sure that everybody understands the procedures that are in place, our safety procedures that are in place. So we've been very detailed in approaching and just walking through all of our procedures and all of our policies to make sure that we've got everything covered. We've distributed information to our medics in the form of reminders. Dr. Hinchy's office distributed, even as early as last night, reminders again about what precautions our medics ought to be taking. We've got a conference call that we're going to do this evening with our commanders to be sure that they're all up to speed on all of the messages that we've sent out and that they know the results of our findings from reviewing our policies and procedures and making sure that we have everything in place. So we've been pretty busy. Those are the types of things that we do fairly routinely on different topics. This is the one that we needed to do today in order to make sure that we had everything lined up. We've been working on it since we first heard of the first cases that came to light. So we've been preparing for quite a while.
Chief, are you concerned about encountering any language barriers in these screenings?
Well, we have a language line that we can activate at any point in time. So if anybody has a language challenge, we use our communication center. They connect us with the person who speaks that language, and they translate for us. So we're not anticipating any issues with language. Very good. Well, I really appreciate you being here.
I'm sorry, I
Oh,
had a
great.
couple of- That Zymex equipment that you all mentioned?
Yes.
for cleaning, that disinfects surfaces, since the disease isn't aerosolized, it's for
Right.
surfaces?
So the way that works is the chemical is distributed in an enclosed space. The ambulance is closed, and through atomization, it breaks it into very tiny particles and then spreads it through the air. Those tiny particles can seep into the surfaces and into the cracks and all the crevices in the ambulance. It's allowed to sit for a period of time for its effectiveness. So it takes about 20 minutes. For each ambulance. We do that routinely. We've been doing it for quite some time. That's actually kind of unique for EMS organizations. That's something that we do that is above and beyond. Most organizations just wipe down the surfaces in the ambulance. But what we do is we run them through our maintenance center, and we use the Zymex machine to further aerosolize the cleaning solution to get a better result.
Was that bought specifically because of the Ebola?
No, we actually bought that in preparation for any pandemic situation that could occur.
We've had it for several years.
Yes, we've had it for several years. We own 2 of the machines, and one of them is located at our maintenance center, and the other is portable. We can take it where we need it.
The other thing I was wondering, what is your message to the public today? Should they be scared, concerned, not worried?
I think the first thing that the public needs to think about is that the risk is low, that there's actually going to be a case here. The other is that emergency services is prepared. We've spent a lot of time thinking through the situation and preparing in case there was a case here that surfaced. Also, there's been a lot of work in our community in preparation for potential pandemic circumstance, anything that could occur that could be widespread. We've been working on that for several years. Our healthcare system here in Austin is superb. There's a lot of work going on, a lot of communication going on to prepare for this and any other circumstance that could occur.
But any concern that this risk could be, could rise a little bit with the ACL, Comic-Con, Formula One is a very international event that's coming to Austin. I mean, are you guys going to step up the measures even more for that?
Well, for EMS, those are the measures that we've got. Those are all our protective measures. There are probably going to be some travel measures that go into place. There's some that are already being utilized throughout throughout the U.S. And we would expect that those will either remain the same or escalate depending on what the need is. But that again, is going to be managed by a whole different group of agencies.